Good morning. My name is Lidia Nagae. I'm one of the neuroradiologists at Radiology Limited, and it's my pleasure today to talk to you about imaging for headaches. Following a brief introduction, we're going to go over the imaging guidelines for headaches, highlight some red flags, discuss different imaging modalities, show some common incidental findings, and review some specific headache syndromes and best imaging approaches. According to the World Health Organization, over half of the world population had some headache last year. Over a third presented with migraines, and headaches for 15 or more days every month affects 2 to 4% of the world's population, adult population. It's a lot of people. It brings a heavy burden to the individuals and to society with low quality of life and high financial cost. Headaches are worldwide, affects people of all ages, races, rich and poor, and in all places. Still underestimated, under-recognized, and unfortunately undertreated all over the world. The third edition of the International Classification of Headache Diseases is a good resource to have, very thorough, but we can summarize the classification into primary headaches, secondary headaches, cranial neuropathies, and of course, other facial pain and headaches. As a neuroradiologist, I wouldn't take this as a joke. I would actually argue that imaging is essential in this case to see the trajectory of the arrow, the structures injured, if there are any vessels nearby, to be able to plan the surgery. So instead of asking myself, CT or not CT, MRI or not MRI, the question would be CT or MRI? And the answer would be CT for diagnosis and preoperative planning, and MRI for postoperative findings and prognosis. What are the advantages and disadvantages of the different imaging modalities? CT, widely available, fast study, lower cost compared to MRI, and it is actually better for detection of acute blood calcifications and evaluation of the bone. It has, however, lower resolution. The exception would be for CT angiogram and venogram. These have higher resolution compared to MRI, MRA, and MRV. It involves radiation, so that is likely a problem, mainly for children, and artifacts mainly from metal devices causing streak artifacts may obscure areas of interest. Everybody loves MRI. It looks like a real, a true picture of the brain with high resolution, doesn't involve radiation, but it's not always available. The studies are longer. Some patients cannot tolerate. Artifacts may be a problem, not only from motion, sometimes even the body habitus can bring up some artifacts. The cost is higher, and nowadays with all these devices and implants we have for treatment of all sorts, safety may be an issue. The American College of Radiology has an appropriateness criteria for imaging headaches. After a review of the literature and a panel of experts, they recommend guidelines for imaging. And this is reviewed from time to time, and there is a version for adults and children. The very first statement is that imaging is actually not required for the majority of cases in headaches. But then they go over specific scenarios that they call variants, and these variants are severe or sudden onset headache, papilledema. The red flags are trauma, cancer, immune compromised state, pregnancy, patients older than 50, headaches related to activity or position, headaches with abnormal neurological exam, migraine or tension type headaches, trigeminal headaches, and chronic headaches with and without new or progressive features. So it looks like this. For example, variant 1, sudden severe headache, or like worst headache of life for initial imaging. A CT head without contrast is usually appropriate. If there is any finding on the CT or depending on the clinical scenario, a CT angiogram with contrast may be appropriate. In this scenario, MRI, MRA, CT with contrast is usually not appropriate. Classic migraine or tension type headache with normal neurologic exam, usually no imaging is necessary. Chronic headache, no new features, normal neurological exam, no imaging necessary. However, if we have a chronic headache with new features or increasing frequency, then an MRI without contrast or MRI without and with contrast are usually appropriate. A CT without contrast and CT without and with contrast may be appropriate. Another good resource is the Johns Hopkins Medical Imaging website for provider information. They have a list of different imaging modalities and the indications below. For example, if we have a headache and we suspect carotid or vertebral artery dissection, ipsilateral Horner syndrome, or we have initial head CT showing intracranial hemorrhage, which is suspicious for a vascular etiology, either an aneurysm or a vascular malformation, we should then have a CTA head and neck with contrast or an MRA head and neck with contrast. So putting both of them together, severe or sudden onset headache, we already discussed. CT without contrast, consider CT angiography. Papilledema, MRI without and with contrast, consider MRV if we're thinking about venous sinus thrombosis. An MRI without contrast and CT without and with contrast may also be appropriate. For our red flags, it's going to depend on the scenario. For trauma, CT without contrast. Cancer, immune compromised state, MRI without and with contrast. For pregnancy, we don't want to have radiation or IV contrast, so MRI without contrast, so on and so forth. For migraines or tension type headache, no imaging necessary. For trigeminal neuralgia, we're going to discuss this a little bit later. MRI without and with contrast, we do have a cranial nerve protocol that is very suitable. We can also consider MR angiogram. For chronic headaches, we saw that MRI without contrast and MRI without and with contrast is usually appropriate if we have new or progressive features. So let's go over some imaging. In the acute scenarios, we have subarachnoid hemorrhage, and the ideal imaging modality, CT without contrast. It has a very high negative predictive value. We know that acute blood is hyperdense on CT, and even small amounts may be detected on CT without contrast. Over time, it gets isodense and hypodense and also washes out, so it decreases the sensitivity. There are studies showing that MRI would be equally or even higher in sensitivity for detection of subarachnoid hemorrhage. This is not what I see in my practice. And if there is persistent clinical concern for subarachnoid hemorrhage with a negative CT, I would recommend lumbar puncture to be performed. CT may also help us with the setting for the subarachnoid hemorrhage. Usually we would like to have a history for trauma, but it may be spontaneous and may be related to blood thinners. Perimesencephalic subarachnoid hemorrhage without an aneurysm is a different entity, but of course, like we have subarachnoid hemorrhage in the interpeduncular cistern, but we still have to rule out the presence of an aneurysm. If there is accumulation of brain suggestive of an aneurysm, we can go ahead and do a CT angiogram, and it's readily detected. Subdural hematomas in the acute phase, we have the crescentic extraaxial collection, hyperdense acute blood. Over time, subacute, it gets isodense, and chronically, it gets hypodense. It's not uncommon to have acute on chronic subdural hematomas. Headaches may not be so prominent, and the patients might come to medical attention actually when they have a cognitive decline or a neurological deficit. Here on MRI, same thing, T1 post-contrast showing bilateral hemispheric subdural hematomas. 47-year-old female with headaches and weakness for 1 week, thickening and hyperdensity along the falx. My first impression was acute subdural hemorrhage, a little bit of subarachnoid hemorrhage, some foci of intraparenchymal hemorrhage, but without any configuration of suggestive of hemorrhagic contusion, and actually no history of trauma. What would give us all these findings? Venous sinus thrombosis should be thought of, and sure enough, there is hyperdensity, like a fresh clot in the superior sagittal sinus. This could also be venous congestion. Findings were confirmed with MRI. MRI also helped us exclude complication with a true infarct. We had a venogram at the same time that showed absence of flow-related signal along the superior sagittal sinus, right transverse and sigmoid sinus, confirming venous sinus thrombosis. Sometimes if we have artifacts or the venogram, MR venogram is not really confirming venous sinus thrombosis, we can still have a CT venogram and use this as a problem-solving tool. I would like to talk a little bit about RCVS, reversible cerebral vasoconstriction syndrome. I'm pretty sure I never heard about this diagnosis when I was in medical school, in residency, never saw a case in fellowship, but then all of a sudden when we are practicing, these cases actually show up. Typically coming with a thunderclap headache. There is reversible vasoconstriction of cerebral arteries, usually large or middle-sized arteries. And the tricky thing is that this vasoconstriction may not be identifiable at the very beginning, and actually it undulates over the course of the disease. So if you're not thinking about this diagnosis, it may be very difficult. It affects young adults, but has been described in kids, female predominance. It may be spontaneous or secondary to exogenous trigger, such as substance abuse. Complications are subarachnoid hemorrhage, seizures, PRES, posterior reversible encephalopathy syndrome, and cerebral infarcts. The overlap with PRES is such that some authors actually believe that it is part of a spectrum, RCVS and PRES. Usually the prognosis is good with complete resolution and no recurrence, but 5 to 10% of our patients may have permanent disability or death. Here's a case from the literature, thunderclap headache, CT without contrast showing small amount of subarachnoid hemorrhage. At presentation, a CTA of the head was normal, but then over the course of the disease, we could identify some vasoconstriction, this beaded appearance of the vessels on angiogram, which resolved over time. Another case with MRI findings on axial flare, typical for PRESS. So this T2 hyperintensity, cortical, subcortical, in bilateral posterior lobes, vasoconstriction, and then over time, complete resolution of the findings. Whenever we're talking about headaches, I think in the back of our minds, we're thinking, oh, might our patient have a tumor? And sometimes, unfortunately, this is the case. This is a recent case shared with the group by Dr. Bennett, 7-year-old male, headaches for 2 years, first MRI showing this large, complex, solid, cystic, partially enhancing mass, T2 hypointensity suggestive of associated calcifications. The lesion is centered in the suprasellar cistern, very suggestive of a craniopharyngioma. Another case when we have tumors which compress the fourth ventricle, as seen in this case, we might have hydrocephalus, and this might bring, earlier symptoms, and the patients come earlier to medical attention. With imaging, we might have incidental findings, and these may bring anxiety to our patients, and we have to give them some reassurance. Developmental venous anomaly is an embryological remnant draining normal brain, and usually of no clinical significance. Some case reports are shown in the literature with thrombosis or hemorrhage, and it's always debated if the hemorrhage is caused by an associated cavernous malformation, which can happen in about 20% of the cases. Usually no follow-up necessary, just reassurance. Arachnoid cysts, this one in the right middle cranial fossa, they may be very large. There is remodeling of the adjacent brain structures, usually no clinical significance. Rarely they might have hypertensive regimen within, but usually they would then show some clinical manifestation. Young female patient with migraines, incidental finding of cerebellar lipoma, likely of no clinical significance. This happens during development, so likely brain plasticity took care of this. There's no reason to follow up, just reassure the patient. Pineal cysts, we used to follow them up for years. And now it's established that if we have at least one MRI with contrast and we see very regular walls for the cyst, no nodular enhancement suggestive of a neoplasm, there is no need for follow-up. Some people even dare to say that they don't need contrast. And if the walls are very regular and you have no nodularity, it is a simple pineal cyst. But I still prefer to have at least one contrast enhanced study. Of course, there are cases of, and we see sometimes intracystic hemorrhage, and they might also increase in size, but usually with clinical manifestations. It is known that patients with migraines have a higher incidence of these non-specific white matter T2 hyperintensities at an earlier age compared to chronic small vessel ischemic disease that we see usually after the 60s. This can happen in patients with migraines in their 30s, and we have to be reassuring. In 2021, there was a paper reported in Nature showing that if there are no vascular risk factors, there is no clinical significance for those T2 hyperintensities. It's not related to severity of the migraines. There is no prognostic value, and it's not related to the migraine type. The fear of, having these white matter changes in patients with migraines, I think comes from the fact that we are always thinking, are we missing something? Does this patient have, for example, multiple sclerosis? Remember that multiple sclerosis is a clinical diagnosis. Imaging can be very suggestive, and that would help, but it is a clinical diagnosis. CADASIL is one of the white matter diseases which may present with migraines, but usually you also have cognitive problems, psychiatric problems, and it is an autosomal dominant disease, therefore with a strong family history. It's a true arteriopathy with subcortical infarcts, as we can see here in the centrum semioval on the left side, a thalamic infarct on the right side, and the distribution of white matter disease is usually very typical. So bilateral temporal pulse, external capsule, and then as we see in chronic small vessel ischemic disease, T2 hyperintensities in the basal ganglia and central pons. And in keeping with a true arteriopathy, multiple microbleeds have been described on susceptibility and gradient echo images. Idiopathic intracranial hypertension happens in females and is related to obesity. It's an underdiagnosed syndrome, clinical presentation with headaches and papilledema with risk for vision loss. And there is intracranial hypertension in the absence of a true brain lesion or other secondary etiology. In this setting, imaging may be very helpful because in a young female, you would expect a prominent pituitary gland, and instead we have a partially empty sella. Be careful because partially empty sella may also be a normal variant. We usually have some downward displacement of the cerebellar tonsils, flattening of the posterior globes because of the intracranial hypertension, and we might even have very typical MRI findings of papilledema with inversion of the optic nerve heads, tortuosity and prominence of the optic nerve shift complex with enlargement of the surrounding CSF spaces. If we do an MRV, we might identify areas of stenosis in the venous sinuses, and therefore an MRI of the brain in consideration for MR venogram would be the best imaging approach. On the other hand, with spontaneous intracranial hypotension, we have orthostatic headaches secondary to CSF leak, predominantly seen in females. If we don't have a history of like a recent lumbar puncture performed, imaging may be very helpful. MRI without and with contrast would be ideal. We usually see dural thickening and enhancement, venous congestion, everything kind of trying to keep the pressure inside the intracranial compartment. There might be even development of subdural hematomas. There is this downward displacement of the brain structures described as sagging of the brainstem. The pituitary gland becomes very plump with the superior convex contour and effacement of the suprasellar cistern. And it's amazing how it all goes back to normal once an efficient treatment is obtained. So there is increased obesity in the world. And with that, there is intracranial hypertension, and the arachnoid granulations that usually are there, they might increase in number and size. There may be development of micromeningocele. These may burst, and it may cause CSF leak with intracranial hypotension. On T2 axial images on MRI, these are the arachnoid granulations. Here on axial CT, these bubbly structures with very thin bone. It's difficult to say sometimes if there is dehiscence. On MRI coronal T2, identification of these micromeningocele. On the CT, we see the dehiscence of the bone. We may have a heavily T2 weighted MR image. We call this MR cystinogram, identifying the microencephalocele. 3D reconstruction of the bone showing the same findings. So it's very important if we are concerned about CSF leak to try to actually document that. If there is rhinorrhea, a beta-2 transferrin, which is exclusive to CSF, may be obtained, confirming CSF leak. If not, we have to review the case clinically before going to all this imaging algorithm. So it's very helpful to have an MRI with contrast in the setting, because then we know that we do have to go over all this. So next step would be a high resolution CT. We can also do an MR cystinogram as we demonstrated before, and leave CT cysternography and nuclear medicine cysternography for more complex cases. So again, if we have rhinorrhea, beta-2 transferrin may confirm that, and then a high resolution CT might be enough to identify the bone gap and then have it fixed. Otherwise, a CT cysternogram, if there is doubt what is the site of the leak, it can pinpoint that site. MR cystinogram also may be helpful. And remember that CSF leak may also come from the spine. Those bone spurs may tear the dura and then cause CSF leak here, shown accumulated around the thecal sac by CT myelogram and here MR myelogram. Lastly, I would like to talk about trigeminal neuralgia. Neurovascular compression is one of the most common causes. Here we have a key sequence on an MRI axial. It is part of our cranial nerve protocol MRI, showing the pons and cisternal portion of the trigeminal nerves. The neurovascular compression actually happens in the transitional zone, very close to the pons, also sometimes called the root entry zone. This is where the central and peripheral myelin meet, and this is a site vulnerable to compression. Then you can have demyelination, and over time, even axonal degeneration and atrophy. Here on this paper, a superimposed images of an MR angiogram, here in red, showing compression in that region, a tractography showing abnormal trigeminal nerves. So if the patient doesn't respond to medical treatment, a piece of Teflon may be interposed between the nerve and the vessel with good results. Here's is one of our cases. So we do have an MRI head cranial nerve protocol. I would also suggest MRA to be done at the same time to facilitate identification of the vessels conflicting with the nerves. Usually they are arteries, but it also may happen with venous structures. These images allows us to get reconstructions and show the proximity of the vascular structures with the nerves. The only problem is that sometimes we see that also in the contralateral side. This patient had right-sided trigeminal neuralgia, but the left side also shows the same findings. And sometimes we have these findings with without symptoms. So clinical correlation is very important. In summary, we had an overview of headaches. We went over imaging guidelines, talked about the red flags. went over different imaging modalities, incidental findings, and hopefully interesting cases which will help you in your practice. And with this, I thank you very much for your attention, and I'm happy to answer any questions you might have. Thank you very much.